Welcome to the School of Radiology. It's our pleasure and honor to welcome you to a 1.5 hour evening symposium. Great, you are back. And yeah, for those of you who have been with us, you know the first 10 minutes we take it easy, especially if we are in such a huge group today. So we have more than 400 registrations, which is a new record. Please feel free to switch on your webcam during the session. It's not a must, but it always creates a nice atmosphere if we see at least some faces. But if you said, oh, I've been working the whole day, I've been running the show in the office the whole day, I just want to relax for 1.5 hours, that's totally fine. We are here to learn a little bit from one of the pioneers, leaders, opinion makers in the field. And this is Mark Lopes. I will introduce Mark later on. For now, I will just quickly give some some background about us. Not to eat time, actually, but just, you know, it has to be personal. It has to be kind of together. It's not like top-down teaching at the School of Radiology. And this is why I'm so happy to welcome so many of you back at our symposium, because I just went through the list. Like 1/3 of you have been here before. So happy that you liked what we're doing, and the other 2/3 a warm welcome to the School of Radiology. This symposium will be about Mark Lopes and his great vision and knowledge, but also we, the hosts, are super happy that you are here. My name is Matthias, professor at the University of Erlangen, and also running this little platform together with Pascal Baltzer, professor at Vienna University Hospital. And this obviously is the Contrast Enhanced Symposium together with Mark Lopes. The second edition on this year, spring edition, was super successful as well with Maxime Jorkelsen. If you haven't seen it yet, go to our YouTube channel. I'm going to share the link later on and watch her great lecture about CEM and her great cases. So just a quick virtually slideshow about us. So we are really passionate about sharing knowledge and sharing teaching in radiology, and this is why we're doing these many symposia also for free. We have been starting our joint journey together as a team in Jena, a little university town, and already in these years, like 15 years ago, this picture all has been about teamwork, has been about vertical, not top down, but vertical communication and teaching. And this is just a snapshot. Hi there. This is just a snapshot of our team back then, because we were still students, but there was no professoriosis, as Laszlo Tabar calls us. Even Professor Werner Kaiser, he talked to everybody, not depending on the academic level. And this is what we want to do also today. I cordially invite you to share all your questions with us. Send them directly to me to the chat. I'm gonna collect them, and then we will have an awesome panel discussion together with Mark later. We've been doing teaching, obviously, in omnichannel formats, and this is a face-to-face teaching course last year in Malbo. But we really think that doing it online is a game changer, not only because of the pandemic, which is gone, fortunately, but because it's so beneficial. So why are we running this little platform? Well, because it's independent. I mean, talking about innovations is always talking also a little bit about pressure from the industry, which is there. Think about the AI hype currently, and I think we as radiologists should have a forum at least where we can exchange outside the circles of commercial interest. Obviously, commercial collaborations are essential, but we also need platforms and symposia like this where we are just amongst us, the radiologists and technicians. A warm welcome also to the technicians who joined our invitation. Image quality is key, and there you cannot share it better than during a live stream. We have high definition streaming here. We have got the premium bundle with Zoom, so we have 2K resolution, which is, I think, important when we talk about Zoom And Sam, it's worldwide. I'm so happy that looking at the map of all our attendees, 60 plus countries are joining us, 400 plus registrations. Just imagine how this would look like at a conference. This is really, really amazing. It's up to date and it's easy to schedule. And I just let in the last registrants from the UK, a warm welcome, who just registered virtually 2 minutes ago. And it's about being together with friends. And it's just a little snapshot we took at our booth at USOBI 2 weeks ago. And it's all about interaction. Interaction means we want to know about your background, why you are here, why you are interested. And this is why I'm now going to open a poll about your background, how you found your way to us. Yeah, and what is your experience and your expectation regarding SAM? Take your time, answer it, answer the poll, and go through all questions. It's not about an examination, it's just for us that we have a feeling what is your background, what is your expectations, why you think this gonna be interesting for you. And this gonna be important for us as the moderator, Pascal and myself, when we lead the discussion later on. And while you're filling out the polls, we are also passionate about coaching and teaching in contrast enhanced mammography. We're doing free case reading sessions. Next gonna be on November 6th. It's a 1 hour evening session. And if you're interested in the real thing, or a whole day course, there's also a 1 day full day course, November 11th. And don't miss the early bird registration rate because they're going to be a 50% discount. This is not about commercial show, just to give you a feeling what we are doing. There are courses with Laszlo Tabar waiting for you, breast MR courses. And while you are filling out the polls, I've seen that 45% already have answered. Make sure that you just answer this poll. Again, this is not about examination. It's just about us getting some feedback, which kind of colleagues we are dealing with. And we're also doing prostate, obviously, and there are a lot of videos available on our YouTube channel and on our webpage, which you can watch later on demand for free, of course. And I'm also really grateful that Mark agreed that he will share his lecture also on our YouTube channel, plus his own, to distribute his amazing knowledge. And hopefully after this session, you will agree that it's also a little bit about fun joining our symposium. Talking about, let's have a quick look on our today's agenda, because we're already approaching the end of this intro section. So in a few minutes, Mark Lopes gonna enter the arena. The Mark Lopes, the pioneer in contrast enhanced mammography, and he's gonna give his keynote lecture entitled State of the Art. And Pascal, while I'm checking the polls and interpreting the polls, maybe you wanna introduce our dear friend and guest today, Mark Lopes.
Mark is really, if you think about Europe, and I hope I won't hurt the feelings of anyone else, I think he's the face of contrast enhanced mammography in Europe. He is also a good friend and working closely together with Maxine Jockelson, who is actually the face on the other side of the ocean. Mark Lopes is working in Maastricht, and I think, Mark, you know that I once applied for a position there. So practically we just barely missed each other. What could we have done together, right? So Mark is currently, I think you are head of the board of directors. Matthias just put it there. You can actually read it. Now the horrible pronunciation of Germans of the Dutch language of the Zuiderland Medical Center. You will correct me, Mark. He worked for a long time in Maastricht University. He explored really contrast enhanced mammography in many aspects. He did really great studies. And one of the reasons, not because of his great experience, because our platform is teaching radiologists from radiologists to radiologists. He's also a very convincing clinician and a very convincing speaker. And even though we sometimes may even have a conflict of interest, as I have to admit, I am still, even after doing a couple of years of contrast enhanced mammography, I'm still a bit of the MRI fanboy. But Mark is so convincing. He nearly got me when I heard him last in Milano. And Mark, I'm very much looking forward to your talk.
Thank you so much. And thank you, Mark, for joining us. It's really an honor. And before we just jumping right into the lecture, just have together, and this means also you guys at home, just a quick look about what we are, where we're coming from, and yeah, because this is, I think, also important for us, Mark, to know. So we have obviously people who are mainly breast imagers. This is clear because CEM is really something for the advanced people. But we have also people, and I'm happy about that, who are hardly doing any breast imaging. So this shouldn't be only like a nerd symposium. This is for everybody. But the clear focus, obviously, is breast imagers, sure. And the same is true for the spectrum of experienced. Roughly half of you have like an experienced more than 10 years. But I think, Mark, what is more important, you may scroll down yourself, although the vast majority of you are, if I may call it so, hardcore breast imagers, only 64%, well, 64% say, I'm a really beginner in CEM. And this is why we need people like you, Mark. There are so many people talking about CEM and advocating it. But if we go to a session like this, having like super experts here, 64%, well, I'm still a beginner, and intermediate, another 29. So experts and advanced people, only 8%. And this probably includes you, who also answered the poll. Probably you're the only expert because there was only one. Anyways, I think this is really gives us a feedback that this format is important. And just for a matter of fun, I set up the last question, Mark. We may repeat it after symposium. I just gave some, like general indications. Maybe this is helpful. Maybe not. You may ignore it. But I think the winner is staging. And you probably will like that. So 41%, it's the greatest role, but all the others are also very well. But there are still people who do not know where I'm going to use contrast-enhanced mammography. So this is just the quick intro. I promised it to be quick. I promised it to use a little bit the technology. And this means that we are ready to go. I will go now step into the background, but before that, we will open a poll which will run during the whole keynote lecture of Mark, and this poll is intended for you if you want to have a certificate. So this has to be filled out by you correctly. Make sure that the email is exactly the email where you have registered. Otherwise, we cannot send you the certificate. And this is why I repeat the email twice. Right? So take it easy. You don't have to answer it now. The keynote will be about half an hour, 45 minutes. So you can fill it out in the background, but this is important for the organization and for your CME credits. So without any further ado, Mark, the podium is yours. We're so happy to have you. And more important, we are also grateful because we know how busy you are. And yeah, thank you very much.
Thank you, Matthias, Pascal, for your introduction and your kind words. Again, we know each other a long time from USOBI, ECR. And when viewing at the photos, I can still remember the first time I met Pascal with the long hair. So I can still remember that all the way back. Together with Carla Buttes, who was still among us at that point. I think we had great discussions, and again, people can be in favor of MRI, people can be in favor of tomosynthesis. It's not really a competition. I always quote something which I picked up from the internet: life is not a competition, it's a journey. And this is how I see the joint modalities that we have. Contrast enhanced mammography. It's just exciting to realize that we live in an era in which so many technical possibilities are at our fingertips. I've never planned to become what I call an expert in contrast enhanced mammography. The actual story was that my professor in breast radiology, Carla Buttes, who was training me at that point as a resident, saw something interesting at a secret room meeting in GE Healthcare. That's actually the way it happened. And she returned, and we were working closely together. And she said, I saw something interesting. We need to look into this. So I said, well, okay, Carla, let's have a discussion when we have time. And unfortunately, maybe in that week or the week after, she unfortunately passed away. I needed to take care of breast imaging department that we have at that point. So there was a lot of emotion, but a lot of responsibilities as well to take over. And maybe after 4 or 5 weeks, GE contacted us again and said, well, what about our plans? And I said, the only thing that I can remember is that she said, we saw something interesting. So I said, the only thing I can think of is send me to your secret room meeting as well. I saw a prototype, something that they were planning to launch in 2012 or 2011 from the top of my head. And it sort of appealed to me. The ease of the use appealed to me. It's something which you can sort of easily implement in your department. So I became enthusiastic. I took it back to Maastricht. I convinced my head of department to invest in that technology. And I learned from one of my colleagues back then, Tim Leiner, who's a very well-known professor in cardiovascular imaging, now working in the USA. With CT cardio, he already made a database from every patient, just like drips of water, one by one, he filled in the database. And I started doing that with contrast-enhanced mammography as well. Within no time, within 1.5 years, you have 100 to 150 cases, and then it's really nice to do all kinds of science on that. And that's how you end up becoming an expert in contrast-enhanced mammography. So no planned professional, no hidden insights or anything. It's just something that appealed to me. But without further delay, I will share my screen for the presentation. Let's see if it works. That's always the interesting part. Let me know, Pascal or Matthias, if it's not working, but I see a thumbs up. So again, I'm very honored to speak at this School of Radiology Symposium. I think the principle behind it appeals very much to me. It's sometimes basic knowledge, which I think we sometimes overestimate, that we still know these kinds of things. I always like to just go to a symposia with just reviewing simple conventional chest x-rays, just to learn again the basics and work from that again. Also, sometimes it's nice to know that I still know my things and that I am confident when I'm going on call and I do other things than breast. So to start off, this is always something that we need to show as well. The disclosures, you can read it by yourself, but it's not something very spectacular. So when I always start talking about contrast-enhanced mammography, I always take a step back and go back to normal mammography, full-field digital mammography. Everybody's doing digital mammography nowadays. And it's still a very good breast imaging technique. It's easy, it's cheap, you can read it rapidly. Yes, there is some discomfort in the compression of the paddles. We know that. Several developments are happening there as well with the design of the paddle and other strategies. But it's still a very good modality, not only for the detection of breast cancer when you, for example, have a palpable lump, but also for everyday screening of average risk women. Now, as a radiologist, we already know that the sensitivity and the specificity, and mainly the sensitivity, is very dependent on the density of the glandular tissue, which has been an item of discussion for many years now. And as a radiologist, we divide it in 4 categories, and you can call it A, B, C, D, or 1, 2, 3, 4. That can change a little bit depending on the department that you are working. But on the left side, you see an example, what I call in literature, a fatty breast, which contains a lot of fatty tissue and only a small amount of glandular tissue. And on the right, you have what they call the extreme dense breast tissue. This contains a lot of fibroglandular tissue and only a very small amount of fatty tissue. And there is, of course, an intermediate category B and C. Now, the sensitivity drops quite strikingly when you look at the numbers that I've put on them right now. This is, I agree, it's an old study, but it's still a very large study based on screening mammography with digital mammography. So there's no reason to think that the numbers would be quite different nowadays. So when you look at the fatty breast, it has a sensitivity which is quite high, 87%. And I want you to remember that number when we compare it to contrast-enhanced mammography later in the presentation. But if you look at the extreme dense breast, the sensitivity drops to 63%. And in fact, that's only a little bit more than flipping a coin. So it feels always a little bit awkward to give people a modality of screening in these category of women, which is slightly better than just guessing. So from history, there's always been some attempts to compensate that lack of sensitivity, either with tomosynthesis or ultrasound, or when you look at the latest results on MRI, the DANCE trial, use MRI as an adjunct modality. And contrast-enhanced mammography is just another modality that tries to improve the overall diagnostic accuracy of mammography. Now, how does it work, contrast-enhanced mammography? I will show you the protocol of acquiring such images in a minute, but this is just a plain case of a single breast cancer in the left breast visualized with contrast-enhanced mammography. So what we see as a radiologist, we see a normal mammogram, which is called the low energy image. And on the other hand, we also see images that contain contrast. These are called the recombined images. That's the terminology that was proposed by the Byrat's lexicon. In older literature, you still see the subtracted images or the iodinated images, but in fact, the proper terminology is the recombined image. And I think that justifies the principle behind it, because it's not just plain subtraction. These differences are very small. So there's also a lot of post-processing going on to increase the contrast in the image a little bit more. So it's subtraction with a little bit of extra. So I think recombined is the proper terminology for these kinds of images. Now you have them in a standard case, you have them for both breast and also in the two views that we are acquainted with. This is the MLO view, but of course there's also the craniocaudal view in the breast, and you can even perform special views if you would like that. Now in this case, it's very obvious on the mammogram to see the very large mass, but I think you can already appreciate the central necrosis of the tumor on the recombined images. There's a lack of enhancement in the central part of the mass, but you can much more easily appreciate the satellite lesions which are surrounding that lesions. And if you're familiar with MRI and you know that this is a young woman, you can sort of already guess a little bit what kind of tumor this will be. And even based on these images, you can already suggest that it's probably a high-grade tumor, triple negative, HER2 positive, something ugly, something aggressive. And that's mainly an advantage if you have a lot of experience in MRI, that you can easily apply those same principles of thought on contrast-enhanced mammography as well. Now, how do you get such images? So the image protocol is very straightforward. In our department, we assess the risk of contrast-induced nephropathy and the risk of encountering hypersensitivity reactions. And you can actually do that in the same way you are used to doing with CT examinations. It's not a different contrast. It's the same product that you use in CT examinations. So if you want to take the safe road, you can sort of align these protocols, and then you have at least the proper protocols that allows you to use iodinated contrast agents. Now, from years of experience, we changed it a little bit based on studies that we did. And right now we use a questionnaire of outpatient people who are attending the mammography suite. And if they fill out everything with no, we know from a study that we did that the chances of them having an eGFR below 30, which is sort of the risk indicator that we have, that's the threshold that we use in our department, the chances that they become below that level is negligible. It's almost zero. There are only a few uncertain cases, but in the majority, you can say that it's safe to use that questionnaire. If you answer everything with no, chances that you have a relevant renal impairment is zero. Of course, you can ask for hypersensitivity reactions, but if they're not known, you just have to work with that. And that's why you always need to take into account that hypersensitivity, although rare, they can occur, and you can cope with them the same way that you do on contrast-enhanced CT examinations. So we have an emergency kit, we have EpiPens, we train our staff, everything is the same as on a CT department. We inform the patient about the procedure. It's a little bit different than just mammography. You place an IV line, you give contrast. So we inform them a little bit more about the standard mammogram. Everybody's sort of familiar with mammography, but not everybody is familiar with contrast mammography. So we take a little bit more time to inform these patients. Now, you start off with placing an IV catheter, preferably in the arm, and we check the patency of the flow just with a simple saline flush. Then we administer iodinated contrast using an automated injector, also again followed by saline flush, just to clear out all the lines and have all the contrast within the patients. Now, a lot of times I'm being asked, well, do you really need this automated injector? And the actual answer is no. We are not doing any timing. It's not a dynamic scan, so we're not really timing it on seconds. We do the image acquisition after 2 minutes, so there is some time in between the injection and the image acquisition, but it makes your life easier. Sometimes you have 100 cc, 120 cc's of volume. You have these big 50 cc syringes that you need to administer through a very small IV catheter, and it takes a lot of pressure to administer. It can be done. If we have technical issues or service, we do it without the injector. But if, like us, you do 3 to 5 examinations each day, it gets a little bit strenuous, and an automated injector just makes your life easier. The contrast dose that we use is preferably over 300 milligrams per milliliter. There are some other departments that use 350 or 370, but in general, the most commonly used protocol is this, and we use a dose of 1.5 milliliters per kilogram of body weight, and we top it off at approximately 100 cc. Others do 120 cc's, but I think that's already quite a large volume when you compare it to CT. And perhaps in the future, there's some room for improvement there as well to lower the total volume of the contrast a little bit. And I think that's still a little bit unexplored territory to see if we can fine-tune the protocol a little bit more there. The automated injector speed is just 2 to 3 milliliters per second. It's very easy flow. So you inject the contrast in approximately 30 seconds. That's also the time when all these side effects start to occur, like having a warm sensation in your body, feeling nauseous, have a bad taste in your mouth, all these reported symptoms. But they also clear out in the next 30 minutes. So after approximately 1 minute, the patients usually indicate to us that they are ready to go. And we ask them to stand up. If there's no dizziness, we walk to the machine and we perform after 2 minutes the mammography examination in the same way that you used to do. There is some discussion about whether you want to do the affected breast first, but that also implies that you know where something is going to happen. We see sometimes contralateral breast cancer. In recalls from screening, we sometimes see that the other breast is affected in 4 to 8% of the cases. So there are a lot of exceptions to that rule. And in the end, we just decided, well, it causes a lot of noise for the technicians. They become confused. They say, okay, we start with the right breast, right? No, it was left. No, are you sure? Let's check. And then you lose time. So it's doable to do it within 10 to 12 minutes. But if you start discussing about which side you need to start, you lose valuable time. So we just decided, and we encounter no big issues over the past years, just do your mammography as you always do, without any stress, without any stress about the time. A well-equipped mammography technician can do a single mammogram in approximately 5 to 7 minutes. So you still have room for special views, and that's why I always recommend that the radiologist should be in the room to help with any kind of hypersensitivity reactions, or is close by and reviewing the cases as they come in, so that if you need to order a special view, you can do it immediately within the time frame of 10 to 12 minutes, and works perfectly. We do not remove the IV catheter until the very entire examination is done. So even if you do an ultrasound or a biopsy, just leave it in. It's there. It doesn't cause any problems. And you still have a patency for the veins, even if you encounter a little bit later reactions after 15 to 20 minutes. So no rush in taking out the IV line there. Now, how does tumor enhancement actually work? And this is something which is not very specific for breast cancer. It's not even very specific for breast MRI or breast contrast enhanced mammography. In fact, a lot of oncologic imaging is based on this principle. Now, when a tumor starts to grow, these irregular cells start to show irregular growth, they can sort of get their nutrients from direct diffusion from the direct area. That's no problem. It can grow a little bit, but at a certain stage, this process is not enough anymore. So the center tends to become hypoxic. It starts to starve for oxygen and other nutrients, and the tumor still wants to keep on growing. So a lot of angiogenic factors are secreted in the direct environment, And we all have these small vessels, which are still, well, they're laid there, but they're not used. And with these growth factors, they are triggered to become mature blood vessels. And they grow towards the highest concentration, which of course is the tumor as the source of these factors. So in that way, the tumor can sort of design its own blood supply and have additional nutrients again. However, there's one disadvantage with these rapidly formed blood vessels, and that when you look at these cell walls and these tight junctions between cells and on a very microscopic level, you see that they're a little bit, well, rapidly formed, disorganized, and they tend to be leaky to contrast, whether it's gadolinium contrast or iodinated contrast, but they tend to seep out a little bit of the contrast within the tumor interstitium. So for a certain time frame, we have some contrast within the tumor mass. And if we use the appropriate modality for iodinated contrast, it's CT or contrast enhanced mammography. And for gadolinium, it's something with MRI. We can sort of show the enhancement of the tumor versus the background, which is normal tissue with a normal blood supply. That's basically the principle behind contrast enhanced mammography. And if you look to the right, I have the same patient imaged with contrast enhanced mammography. You see the very small mass, which is very difficult to see on your low energy images, but it really pops out on your recombined images. And you sort of see the similar appreciation then of the mass when you look at the T1 weighted contrast enhanced breast MRI below. So it's the same principle, in fact. Now here, it's a little bit more technical. So we have a tumor, we have injected, so to say, a little bit of contrast. So now how are we going to visualize it? And in fact, the whole basic principle behind contrast enhanced mammography is dual energy. So you need two exposures with a different energy level to make sure that you acquire these images. Now, when you look on the x-axis, you have the photon energy, your kV value. And on the green dot, it's the low energy. That's sort of the area which we take a normal mammogram at approximately 22, 24 kV. If you go from that point up, you see three lines. You see two dotted lines and one straight gray line. And these lines all represent sort of, well, actually the mass attenuation coefficient, but it's much more easier to say sort of the X-ray absorption which occurs within the breast. You know, if you increase the energy, the spectrum becomes harder and it passes much easier through the breast. So you get a lot less X-ray absorption. Now, when you look at the green dot and you go up, you see that there are some very small differences between breast tissue, breast cancer tissue, and breast fatty tissue. They're very small, but they are there. So if we acquire an image at that point and we do some post-processing to increase those differences, we get these nice mammographic views that we are familiar with. Now, for iodine, which is the orange line, something strange happens. It shows a slight increase at what they call the K edge of iodine, which is located at the level of 33.2 kV to be exact. It goes up a little bit and then goes down again, like we are familiar to with these other lines. Now you can imagine if you have an X-ray absorption line for breast cancer tissue, which now contains the iodinated contrast, it will also show a slight increase, and it sort of detaches itself again from breast normal tissue and breast fatty tissue. So if we take a second shot above that K edge, doesn't matter where it is, but from practical and technical choices, they decided to do it at approximately 45 kV. You get a second shot where you have a distinction between, on one side, breast cancer, which contains iodinated contrast, and on the other hand, you have breast normal tissue versus breast fatty tissue, and you cannot distinguish these two anymore at this level. So what you get is the following. You have the normal mammogram, the low energy. Then in quick succession, you get the high energy, which is never shown. So you know it's the high energy when you look at the principle, but you don't see that on the PACS unless you send through all the raw data, if you like that, but it's not really useful, as you can see. And in the end, you also have the recombined, which I already explained. It's basically a subtraction, but a little bit extra. Now, to really convince you that there is some information in the high energy image, I sort of windowed and leveled it to the extreme a little bit, and you already see that it's not a completely white image. There is actually information in that image. So this sort of trying to convince you that you see the areas with iodine, you see them much brighter, and the other ones are much less bright, less pronounced. And you can imagine if you subtract those two that you end up with the recombined image, as you can see on the right side. Now, there are some very specific contrast-enhanced mammography artifacts. I will not go into the artifacts that you can encounter with normal mammography, which can be hair in the field of view, or you can have skin folds containing air, and you get these black stripes on your mammogram. That's all the same when you compare it to low-energy contrast-enhanced mammography images. But I want to mention a few very specific recombined image artifacts that we know. And I should also say that these much occurred at the older generation machines. The reason behind that the older machines, the first editions of those, were actually existing digital mammography machines which were upgraded to perform contrast-enhanced mammography, which actually means the first system that we have, it was 2 days out of the running. We popped the hood so we could look at the engine, so to say. We took out several components, put in new, did software and everything, and within 2 days of work, you could perform contrast-enhanced mammography. Now, all the bigger vendors now have a one-size-fits-all system. You usually buy one system with every application inside, and you sort of buy or activate the software licenses to operate the different functionalities of the system. So these artifacts are less and less pronounced with these more dedicated systems. So you should know them. You can very easily understand them and work around them. And please be informed that they are much less pronounced in the latest generation systems. Now, the most important one is the breast-in-breast artifact. That's the one on the left. And that is the sort of loosened band at the periphery of the breast. It's something which has to do with the curvature of the breast, which cannot be fully compensated on your algorithm. And with the latest generation of machines, you hardly see that anymore. But from the older images, you can actually quite easily detect them. When you know the pros and cons of different systems, you can actually spot out in different presentations and different publications which vendor they're using and which prototype or age the system is. But it's virtually gone in the latest system. The same goes for the skin line artifact that has improved much. You can see some suggestion of skin enhancement, but when you look at the upper part and the caudal part of the breast, but when you look at the low energy counterpart, you don't see any tumor there. You don't see any skin thickening there. So you see absolutely nothing happening with the skin of the breast there. So you can safely assume that this is an artifact by the recombined image. What you still see a little bit, but there's also a little bit of motion correction already in the current protocols, is the ripple artifact. These are these small black lines occurring next to Cooper's ligaments or tumors or anything. And that's just a little bit of misregistration. Patient moved a little bit between the image exposures, and you get a slight mismatch. And it usually occurs in the MLO views and usually in the lower part of the breast. Now, a little bit more rare artifact on the right is a calibration artifact. You see in the lateral part, you see a small mass, and you see a square, a little bit darker gray over there. At first, when we had the first system, and when we had service, they took a lot of shots with phantoms, different phantoms, and they sort of get a little bit memorized in the detector. You need to calibrate that, and then it's gone. But of course, you need to calibrate now 2 exposures. And if you do only one and you do not calibrate the high energy exposure, you can still see the phantoms reoccurring in your recombined images. So if you see these small things, remember it could be a calibration issue. If you calibrate and reset both exposures, the artifact is gone. What can be an important clinical dilemma is contrast splatter artifact, as I call it. It's just contamination of contrast. You see these small white dots occurring, and you can imagine on a low energy image, these might simulate microcalcifications, and they can become a story of their own. You do an ultrasound and they are planned for stereotactic biopsy, and at the biopsy, they're gone. Oh no, we need to do follow-up, blah, blah, blah. So you can imagine that this causes a lot of fuss and a lot of uncertainties in patients. But the easy thing is that, as I already said, a recombined image is in the basics a subtraction image. So if there's really true calcifications there, they become black. If you have calcifications and they become bright white on your recombined images, you should at least consider that this might be contrast contamination. Usually there are the mirror view, or they are on both detectors and anything. And the easy way to solve it is just rinse off the breast, rinse off the detector, and take one extra shot to at least document that this was an artifact. It sounds a little bit simplified, but it actually occurs maybe 2 or 3 times each year that the technician has manipulated the line, sort of by the pressure, it shot loose or anything, and you can almost not imagine how these micro droplets, how far they fly to the mammography machine. So remember it, it's very easy to recognize and very easy to solve, but can become a very big story of their own if you're not aware of them. Breast implants. I know some institutes which still do contrast-enhanced mammography with breast implants, but you can see the amount of artifacts that you get surrounding the implant. And then I think, well, what extra image do what extra information do I get there? And again, as I already emphasized before we started, I'm not trying to get rid of breast MRI at all. It's still a very good technique. And this is where I think breast MRI still has the benefit. You can not only assess the integrity of the implants, but you can look up, down, left, right, very accurate to see whether there are tumors. So we tend not to do contrast-enhanced mammography with breast implants. On the other hand, there are some things that you don't like to do in an MRI machine, like jewelry, which you cannot remove or do not want to remove for some reason, or cardiac devices, reveals, pacemakers. Of course, they can go into the MRI, but if you have a very good alternative, why send them to the cardiologist to read out these pacemakers and everything, cause a lot of fuss? You can see you cannot look behind the pacemakers, but they're quite high up in the chest wall usually. But the rest of the image is perfectly normal, and you can assess it very well. Now, from one of the first critics that I got is, well, Mark, you're doing 2 shots per breast and 2 views. Isn't it a lot of radiation that we're going to use? So in the first system that we have, we did a study together with Cecile Jeukens, a good colleague of mine from Maastricht, and it was later sort of repeated by Joanna Phillips in 2018 with roughly similar results. And we looked at one single machine. We still had one single machine at that point, and we looked at the images that this system did on normal mammography, but also on contrast-enhanced mammography. And of course, the radiation dose increases with the thickness of the breast. But if you look at the average, you sort of have a 1.6 milligray of radiation exposure per image for a normal mammography. It's slightly higher for low energy images. And of course, due to the high energy of the spectrum in the second shot of the dual energy mammography, it's only a very small addition. And in the end, we came up with a sort of summary additional radiation exposure of approximately 80% increase when compared to a normal mammogram. There's some differences in literature. Some say 50, some say 20. I think most realistic, it's somewhere between 50 and 80%. Depending on the population that you're looking at, the system that you use, but also the system settings that you're studying. For example, one of the first studies by Clarice Dromain reported the 20 to 21% increase in radiation dose, but that showed the most optimal settings. In contrast, in our study, we looked at the most frequently used settings, which I think is more representative of the average workday that I have. So it's 20 to 80%. More realistically, I would say it's 50 to 80%. Well, next question, of course, is that dangerous? To see whether radiation exposure is dangerous, well, I like to look at these kinds of images. These are the lifetime attributable risk numbers, and it shows you sort of the relative risk that you have by getting cancer based on the single shot that you got from your mammogram. And here in black, it's contrast-enhanced mammography, and in red, it's normal mammography. And if we look, for example, a very critical age, like 40 years of age, you see that the incidence of getting breast cancer by one single exposure is somewhere within 1 per 100,000. Now, if you vary on a popular level, you say, well, you double it with contrast-enhanced mammography. But if you look at the relative numbers, it's still 2 in 100,000. And that is at the age of 40. And if you compare it with the natural incidence of breast cancer and the mortality of breast cancer, these are numbers of a whole different level. In fact, there are even some groups of physicians who say at a certain small dose, there isn't even any DNA damage. That's a whole other discussion, but this is sort of the worst case scenario. And we're talking about a very low radiation dose. Yes, we increase it with 80%, but 80% of a very low radiation dose is still a very low radiation dose. And if you're very critical, this is still a dose which is well below the level which is generally accepted to perform average risk screening. So regardless of the results or the use of the iodinated contrast, when we're looking at radiation exposure, it's still safe to use in average day screening of breast cancer. Now, where do we stand with contrast-enhanced mammography at this point? And I think a good colleague of mine from Milan, Alessandro Cozzi, did a very, very nice review on this. It shows really a sort of an update where we stand now, not only for contrast-enhanced mammography in general, which is represented by the green bar, but also for some specific questions like the dense breast. This is a very often asked question to me. What about contrast-enhanced mammography in dense breast? Well, here you have the numbers. And he has really made a very nice subdivision in the different things that you can do with contrast-enhanced mammography. For example, he also looked at the summary results of looking only at the recombined images. So it's a very useful review, I think, to read, to have an impression what's the power, what's the diagnostic accuracy of contrast-enhanced mammography. At this point, you can see it's almost 70 studies by now. I was very struck by it to see that we already have a systematic review containing almost 70 studies on contrast-enhanced mammography, which sort of shows the momentum that this technique is having. And if you remember the 87% of diagnostic accuracy, sensitivity in the most easy to read breast, which was the fatty breast, this is the general breast population. You see that you already have a plus 8% increase very easily. When you look at the specificity, it's 81%. And we know these kinds of numbers from breast MRI as well. It's a little bit less with the dense breast. Of course, in dense breast, you have more often benign findings, benign changings, which can also enhance and which are probably the reason by the more frequent occurrence of false positives and hence the lower specificity. And when you put that together in a ROC curve on the right, and you look at the summary AUC value with higher than 0.9, it's a very, very good technique in terms of diagnostic accuracy when you look at both sensitivity and specificity together. Now, the comparison with breast MRI, of course, is an obvious one. And one of my PhD students recently did a summary review on that as well, looking at the sensitivity and specificity of contrast-enhanced mammography and MRI in women who underwent both. There are some reviews on that from the past years. They all differ a little bit with the final conclusions, mainly based on the different papers that you want to include or not exclude. So you can agree with our inclusion criteria or not, but we try to keep as closely as possible to the everyday clinical workflow. So papers that we didn't include, for example, were if some kind of prototype were used. Maybe there was a little bit of a different approach with contrast-enhanced mammography. We didn't include it because we think that's not, at this point, the clinical way that you do it. And also for breast MRI, we did not include non-standard protocols. We also know that sort of the standard protocol is with a breast coil, T2, T1, maybe DWI, but that's sort of roughly the standard protocol. So we did not do any inclusion of cases which perhaps did also spectroscopy or very dedicated stuff. This is what we try to simulate everyday clinical practice as much as possible. And when you look at the sensitivity and specificity of contrast-enhanced mammography and you compare it with breast MRI, you actually see no real difference. However, there's one caveat which I really want to stress is that this is only 6 studies. And there's no pro or con or being for or against breast MRI at this point. It looks good for contrast-enhanced mammography as an alternative to breast MRI, but we need much more data. So I would like to encourage everyone who has plans to do study and is always asking, sometimes me, myself, well, Mark, what can I still investigate? Do some basic stuff, because we need data which we can pool, and then we get these interesting systematic reviews. So repeating a study is not something to be ashamed of, but do it in a proper way so that we can actually pool the data. That's the most important take-home message. You don't always need to be the first one. It helps you with get a publication in a high impact journal. I know it's how it works, but it's not something to be ashamed of, to copy a study and to add to the data that we need so we can summarize it in systematic reviews and meta-analysis, but use the proper design so that we can actually do that. Well, where do the potential indications for contrast-enhanced mammography lie? We do it in the Zuiderland Medical Center for preoperative staging of women diagnosed with breast cancer. I will go into detail a little bit more later. Evaluation of women recalled from screening as a problem-solving tool, same way that we did it with MRI for years. We actually do it as a standard matter for response monitoring in breast cancer patients treated with neoadjuvant chemotherapy. We do now, since 2 weeks, contrast-enhanced stereotactic biopsy. Evaluation of women with a prior history of breast cancer surgery when they come sooner than their regular follow-up. So if they come at their annual follow-up, we just do a standard mammogram. If they come sooner because they notice a change in their scar or whatever, we have a very low threshold of using contrast-enhanced mammography. As an alternative to breast MRI for several reasons. Cancer of unknown primary syndrome. I was always taught by Professor Boutes, if you have a mammogram, if negative, do MRI. If you have roughly similar diagnostic performance, why not use it as a one-stop shop? Or when other breast lesions are detected on other modalities. We had this with COVID, which we did a lot of screening with chest CT. So we saw an increase of lesions that were detected on the breast on chest CTs. So anything that sort of has a high a priori chance of detecting a breast cancer, we lower the threshold a little bit to do contrast-enhanced mammography. Now, for preoperative staging, I think the most important thing to mention is that you have 3 important things. You need to know how big is the tumor within the breast. Are there more lesions? Is there a contralateral tumor? You need to look at the axilla, how many lymph nodes are involved, not only if there are lymph nodes involved, but preferably also how many are involved. That's always a little bit of a difficult assessment. And are the internal mammary lymph nodes involved as well? For the purpose of time, and I will like to invite you to read my review, which I was invited to write by Matthias on a European Journal of Radiology. I think it's a very practical, it's a pro CEM perspective. I know, I agree. So I did it with the question, okay, I have a contrast-enhanced mammography and I can do an ultrasound of the axilla in one stop. Where would I still need an MRI? And I sort of, like an onion, peeled off all the layers and tried to really be critical. Where do I still need an MRI? Now, when I teach residents how to look at lesions in the breast, I always say, remember, there's a surgeon standing behind you and they say, what side and how much? That's sort of the very basic question that you need to provide. So left and right is very obvious. You can specify it with a quadrant or distance to the nipple or whatever you're used to. We have the very nice descriptors in the BI-RADS lexicon. And the thing that I want to highlight here is how big is the tumor in millimeters or centimeters, and are there any additional lesions anywhere in the breast or perhaps in the other breast? So when you look at size comparison, Eva Fallenberg was actually one of the first in 2013 to publish some data on that, comparing contrast-enhanced mammography on the left and MRI on the right. And you see actually in these first cases with only limited experience, everybody had limited experience at that point. So you can see there's always a very good correlation already between these initial cases. However, personally, and I learned it from a very good statistician of mine who helped me with these kinds of questions, these are graphs that are predominantly discussing correlation. If you have a measurement which is always overestimating a little bit, you don't have any good impression on the agreement between those two measurements. So what I preferably look at is these kind of plots. These are blunt outcome plots, and for people who are less familiar with that, I would like to take 1 minute to explain it to you. On the x-axis, you actually have the tumor diameter that you measured. So 0 is very small, almost non-existent, then it goes to a very big tumor. Now, the different thing is on the y-axis, you highlight the difference between the measurements that you have. So, for example, if you have a 40 millimeter tumor, you go to the x-axis on 40, and you measured it 60 millimeters on contrast-enhanced mammography, and on pathology it was actually 40 millimeters, you plot a dot on the plus 20 millimeter point. You do that for all cases, and then you get these small clouds, and you always see that very small tumors, which are very mass-shaped, is always very easy to measure. And when it grows, it gets speculations, and it goes a little bit asymmetrical. So you always see that the random error increases a little bit. Now, you can sort of measure an average, which is the continuous line for all tumors, and preferably it's on the 0 line. If you are above, your technique overestimates a little bit. If you are below, it underestimates a little bit. And the dotted lines are sort of the limits of agreement is the official term, but the most easy way to explain it is sort of the confidence intervals, the bandwidth in which the data is lying. And you can actually see that for contrast-enhanced mammography, it was very good with these initial cases, and only a very, very small 2 millimeter overestimation of breast MRI, which of course for a surgeon is not clinically relevant. Now, quite recently, we did this exercise again, but then with 3 hospitals looking at retrospective data for the most challenging cases of breast cancer, the invasive lobular carcinoma, which in general is always considered to be the territory of breast MRI. I fully agree, but we looked at the data. What do we have now for evidence on contrast-enhanced mammography? And again, here you see the numbers for contrast-enhanced mammography. And if you go to MRI, of course, we have much more cases because everybody tends to do breast MRI for these indications. You see that there's sort of a similar approach in terms of looking at the disease diameter. It's a little bit soon to really have robust conclusions, but again, it shows that we really need to have these data as a community. But this first publication, it's looking good for contrast-enhanced mammography. But again, we need much more data on that, specifically since ILCs is only 10% of all breast cancer, so they're very difficult to come by. Now, it's not only about assessing the size, it's also assessing satellite lesions, contralateral breast cancer. So we also looked in this study concerning the ILCs on how good are we at detecting the satellites and how good are we at detecting the contralateral breast. Well, in general, you see that the sensitivity is a little bit in favor of MRI, but the specificity is in favor of contrast-enhanced mammography. Now, diagnostic accuracy, as represented by the diagnostic odds ratio, is always the balance between the two. You want to detect all cancers, but you do not want to generate too much false positives. That's in every diagnostic test, the balance that we need to figure out. And that's slightly in favor of contrast-enhanced mammography. I do not want to give real hard recommendation based on this slide, but it shows a little bit that we're sort of in line. We still need more data, absolutely agree, but you can see where the strengths and weaknesses lie of each modality. This is how it looks in practice. On the top, on box A, you have a mass that was recalled by screening. You can see it very nicely on the MRI, but we also saw a mammographically occult lesion only enhancing on the recombined image, and you can actually see it very nice on the MRI as well. Similar for this case, which I already showed you in the beginning, it's a very small lesion. You see it brightly enhancing in the center part of the right breast, but you can also see similar appearances. You can actually see similar morphology and shape occurring on breast MRI. So to learn contrast-enhanced mammography is very easy, especially if you have a lot of imaging experience in considering breast MRI. Now, this is a slide with my personal opinion. You can debate about that over a glass of wine. I think we can debate all night over this, but I won't keep you up all night or evening or morning, whatever part of the world you are in. But this is my personal opinion, and I put an emoticon behind it on how happy I am with different kinds of dilemmas. So for the preoperative staging, I'm very happy with contrast-enhanced mammography. I'm also very happy with MRI, but a little bit, you see me a little bit more smiling with contrast-enhanced mammography. Why? Because I can offer it much more rapidly, it's much more efficient, it's cheaper, it's much easier to perform, and in a minute, I will show you why with our workflow. Invasive lobulars, it's a little bit the other way around. I'm happy about contrast-enhanced mammography, but there's much more data on MRI. Preoperative staging is a little bit in between. I'm happy with both because you see the calcifications on the low energy images, and you sometimes see the enhancement, but sometimes it's more like non-mass enhancement. You can appreciate the diameter a little bit by doing multiplanar reformatting. So it's a little bit fine-tuning on an individual case. Where do I need contrast enhanced mammography, or do I prefer still an MRI in this specific case? Radiation, of course, is a big smile for MRI. It has no radiation, but still, well, a very nice smile for contrast enhanced mammography, because it's really a relative question. It's really an important issue talking about radiation if you have a very good indication for contrast enhanced mammography. Contrast agent used is a little bit in favor of gadolinium products, of course, but again, a small smile for the iodinated contrast agent, because the latest generation of those products is still very safe in everyday use. Image-guided biopsies was a very big smile for MRI, but it switched around since more and more hospitals are acquiring CESB. It's much more easy to perform. It's like a stereotactic biopsy with contrast. It's nothing more than that. Purchase of a system is a little bit in favor of contrast enhanced mammography. Reading times, it's about seconds with contrast enhanced mammography and minutes with MRI. Same goes for learning curves. When you have 4 sets of images, it's always, no matter what kind of organ you're looking at, much easier than look at scans. Looking at a chest X-ray is much easier to learn, not sensitivity or something, but to learn it. It's much easier than a CT of a chest. Room time is shorter for contrast enhanced mammography, and also I think it's a no-brainer, the price per examination. Where do we still use MRI then? If it's not within the mammographic field of view, some invasive lobulars, which are difficult, so it's not forbidden to do contrast enhanced mammography of breast MRI. In fact, there are some advantages which we have in our hospital. We tend to use more and more magnetic localizers instead of iodinated localization needs or technetium for the sentinel node procedure. We use MagTracer and MagSeed. And the biggest problem there is that you cannot do response monitoring with MRI. Well, no problem. We have contrast enhanced mammography, and you can actually see here, this is a test case without any contrast for ethical reasons. But you see that even pure magnetic tracer, which is the circular wet, you see the water, you see the fluid, but you don't get any image distortion. And at the green arrow, there's the magnetic seed. You don't see any distortion of the image as well. So we use these magnetic products together with contrast enhanced mammography. Now, I'm a big fan of Formula 1 racing, or racing in general, and I always compare breast MRI and contrast enhanced mammography with these two. Breast MRI being Lewis Hamilton, a 7-time world champion, established a very dangerous adversary. Do not rule him out in the next couple of years. But as a Dutchie on the right side, I can see Max Verstappen a little bit as the contrast enhanced mammography. The new kid on the block, which seems to be as fast as Lewis Hamilton. Both have their strengths, both have their weaknesses. So in general, I would like to conclude it's not a replacement for breast MRI. It's an additional modality that we have as the entire breast imaging community. And it's our job to establish where and when we can suffice with contrast enhanced mammography, and where we definitely need breast MRI, especially in the light of an increasing demand in healthcare overall. There's a high demand of healthcare, a high demand of MRI overall. So every slot that I get freed up, it's immediately booked by neuro, MSK, abdomen, you name it. So we really need to be smart. Where do we use it, and where do we still need breast MRI? Now, our approach is a little bit different. We use 2 radiologists, 4 technicians, 3 mammography systems, 2 ultrasound machines. We have a biopsy table and a VAP system. We see approximately 50 patients a day with 450 new breast cancer cases annually. 1 surgeon, 3 specialized nurses. We all work in a circle of about 100 meters in different hospitals, so very dedicated, close to each other. And we have several conditions. We perform all biopsies immediately, regardless whether it's none or 10, we do them immediately. We have a 24-hour diagnostics with the pathology if we enter it before 11 o'clock in the morning. We have daily MDT meetings, and we plan the second outpatient visit immediately after requiring and discussing the results. And we have a lot of experience with contrast-enhanced mammography, so we rely heavily on it. Our aim is not only to provide the results, so say you have cancer, yes or no, but also you have cancer and this is your plan. Because otherwise, I think you're sort of shifting the problem. You know that you have cancer, but the next question is, what are we going to do about it? And we want to offer that service together. Now, this is a simple case of one cancer, nothing, palpable mass, one cancer, and we need an MRI just to rule out additional cancers. So on Monday morning, she gets a mammography, tomosynthesis, ultrasound, and a biopsy. On the second day, usually during our lunch break, we have the MDT, and we decide that she needs an MRI. Now, if you're lucky, within 5 days, you get the breast MRI, which is already very fast. You see no other abnormalities. You discuss it with the multidisciplinary tumor board. And on day 8 in the afternoon, she gets not only the results, but also the treatment plan. With contrast-enhanced mammography, it looks like this. We already see that it's one lesion and no contralateral breast cancer or multifocality. We do the biopsy. And on day 2 in the afternoon, she had not only the results, but also the preoperative staging and the pre-treatment plan. Now, a slightly different, more complex case. Suppose we have an occult breast cancer on the contralateral side, which we are going to detect with breast MRI. So again, similar approach. We have a palpable mass. We think it's a tumor. We do a breast MRI. And on day 7, we say, oh my God, we see something enhancing on the other side. We decide on the MDT that we do a second look ultrasound. We find the lesion, we biopsy it, goes back to the MDT, and then on day 10 in the afternoon, you have the results. Now, when you rely heavily on contrast-enhanced mammography, again, it looks like this. With the first session, you see bilateral cancers, you biopsy them both, and they go in the same processing, and even in these more challenging cases, you have on day 2 in the afternoon, not only your results, but your plan as well. And of course, this is not 100% of the cases go like this. There are still some challenging cases as well, but you can see how much more efficient your workflow is becoming at this point. Now, we also use it for the screening. This woman was recalled for an asymmetry on the right side, no abnormalities on contrast-enhanced mammography. And the way I learned it from Carla is to simply compress it. For those of you, this is something that we did in the early days when we didn't have a large access to tomosynthesis. We tended to do spot compressions for those of you who know it. I still like it very much to do it like this. But you can see, even in the conventional way, there's no abnormality there. Another thing is this was a lesion recalled from screening behind the nipple. It's very, very small, low density mass, which was recalled. And actually what you see there is a black void occurring, which they call on contrast-enhanced mammography an eclipse sign. It's negative enhancement. And this is very a typical appearance of a cyst. This was a woman who was recalled for calcifications. In the detail, it's outlined in the box of the red box, but she actually had benign calcification, and we found something completely different in another part of the breast. And this occurs in about 4 to 8% of our cases in our experience. So this decided us, every experience that we had is decided us to 4 to 5 years back to design the rapid access to contrast-enhanced mammography in recalls from breast cancer screening trial or the RACER trial. And we actually have the results almost completed. I cannot give you the final results because there is a little bit of calculation going on, but I can still give you some highlights where we are at this point. So what we did in this study, we compared looking at a recall with screening based on contrast mammography, or they were appointed to a group with everything that we have, but not contrast-enhanced mammography. So follow-up, mammography, ultrasound, tomo, cytology, biopsy, follow-up until you are 100 years of age. But at some point you have the diagnosis and then you say, this is done. And we calculated how many steps and how many resources needed. Now, the diagnostic accuracy was accurate. So we tend to find out whether somebody has a cancer or not. But the resource that we needed is much, much, much lower in contrast-enhanced mammography. In fact, we subdivided in a BI-RADS 0 route, which is a very low suspicion of breast cancer. We saw, compared with the conventional way, we saw that it's always cheaper, always, 100% of the cases. And in more than half of the cases, it was actually better than we did before. This is usually because it's superposition or assist, which with one press of the button, you can see it's not anything to worry about. Immediate discharge done within one press of the button. Now, the 4 and 5 route were a little bit more difficult. We had a smaller sample size, but our recommendation would be that you should consider it. There's no real benefit or negative effect in terms of accuracy or cost, but at least you're already going down the path with the BI-RADS 5 of preoperative staging, where you don't need an MRI or anything. And those were not included in the RACER trial. It was about the diagnostics and not about the staging, this trial. Now, we almost come to the conclusion of our talk. Contrast-enhanced biopsy, with any proud, we can say we also got our hands on a system. Sometimes people ask, is it difficult? No, absolutely not. My first biopsy, without any experience at all, was within 13 minutes. So if you're adequate in doing a stereotactic biopsy, it's just a stereotactic biopsy with contrast. Rodrigo Alcantara did some preliminary results. It has a very high technical success rate. Complications, well, it's not really related to the procedure, but more with the needle. So this is all the same that we already used, from VAP systems. 40% was something like DCIS or cancer. So it has a very high positive predictive value. Within 1 or 2 scout images, you usually have the target, so that goes very fast. And he reported a median time of 15 minutes, which was aligned with something that the first experience that we have. So it's similar to a stereotactic biopsy, but with contrast. It's nothing more than that. So the last indication that I want to highlight is response monitoring in patients using a contrast-enhanced mammography that are pre-treated with contrast-enhanced with neoadjuvant chemotherapy. So this was always a little bit the terrain of breast MRI. And of course, if we have the possibility with radiomics, deep learning, anything like that, and multi-parametric assessment to predict which kind of chemotherapy is the best, or if you can predict complete response, so we can leave out surgery. But in none of the cases, none of the parameters, that's actually the point at this time. There's a lot of work going on, I know, but at this point, there's no technique, procedure, strategy that can actually safely omit surgery. So in clinic, the only thing that the oncologist wants to know halfway is there stable disease or regression? If yes, we're going to continue the chemotherapy. And that's something which you can easily assess on contrast-enhanced mammography as well, as I show you here. In fact, you can evenly see progression. This was a large tumor. Halfway after 4 cycles, you see the mass diminishing in volume and enhancement. But unfortunately, in between halfway and the end, you actually see the tumor growing again, which was confirmed that in between she had a regression, but for some reason there was some resistance to chemotherapy and it started growing again afterwards. Just to summarize, here you see the results of contrast-enhanced MRI. I just want to highlight the AUC value as a summary of this slide. And when you compare it to contrast-enhanced mammography, again, similar performance. Several studies looked at complete response or residual disease measurements. Again, this is only a handful of cases. You have to be a little bit careful with making really robust statement, but it's looking good if you are in favor of contrast-enhanced mammography. Now, where do we stop? This is all about diagnostics and working in a hospital, but why not screening? We know that in dense breast, normal mammography is lacking us. We know that in our hospital, in our country from the dense trial, we know that from a JSTART study in Japan that we need ultrasound, so we need something extra. And I'm very proud to see that contrast-enhanced mammography has also entered the average risk screening arena with trials going on already in the States, in the UK. And I'm very proud to announce that even in the Netherlands, we're currently preparing the DANCE 2 trial. We still a working title, but it's the same group in general. Again, with women with dense breast, and we're going to compare contrast-enhanced mammography with abbreviated MRI as an adjunct imaging to normal mammography. So very exciting times, very much looking forward to the initial results of the different trials. And I'm actually very convinced that screening is becoming more individualized and contrast-enhanced mammography will have some kind of part to play in that. And with that, I would like to thank you. I'm open for any questions that you have, difficult or very easy. Don't be afraid to ask them. And in the meantime, I will stop sharing my screen. Thank you very much for your attention.
Now, I have the honor to kick off one of the parts which are very dear to me, because it's the interactive discussion, and I already have lots of questions. Hopefully, I won't eat too much of your family time tonight, Mark. But I think it's really worth to discuss as many possible questions, because we do have a great expert here, right? So if I may just jump in, I already sorted a list and prepared it. Let's go through, and you guys who haven't yet asked a question, please do so. It's my job here to be the conductor here. I do have a great soloist, and you are the orchestra who gives me the takes. So first of all, this is also a question from my side, but it's actually from South Africa. How is it possible to get the biopsy results so fast in your department? What's the trick?
A very dedicated team of breast specialists. I always, when people ask, we do not have superpowers. We are just very enthusiastic breast specialists, going from the surgeon to the oncologist to the plastic surgeon. And I think the ideal situation that we some years ago, maybe a decade ago, our hospital was rebuilt. It was a new hospital. So that gives you the luxury of really think critically about design of certain departments. And we really made a choice that we wanted to have a dedicated breast center. And we have a waiting room, which sort of simulates a living room. So we have chairs, we have a TV and everything. People are welcomed by a hostess, and she will show you around. The patient is taken care of. She don't needs to fill in forms or watch the time. They make sure that you're at the right place at the right time. And it's just when you have an enthusiastic group. On my part, I'm very enthusiastic about contrast-enhanced mammography and making that workflow as efficient as possible. The surgeons came up with the magnetic seed localizers. And they asked us, does it interfere with you? And I said, no, actually, it sort of promotes my thoughts as well. And the same goes for the pathology. They have the enthusiasm of designing a fully digital pathology workflow. So the specimens are automatically assessed. And I know it has to do with investment in machines, and sometimes you have to wait a couple of years before your budget is accurate and all these kinds of dilemmas. But it's really an enthusiastic group of very dedicated people who are pushing the board, who are pushing management that we need this. And sometimes you win, sometimes you lose, I know. But in the end, you sort of push your limits a little bit further. And we're not done yet. We want to increase our level of expertise every day that we're working. So it's a lot of enthusiasm about your work.
Lovely. This is super convincing. It's all about passion and getting stuff done, right? It's not the magic bullet point. Wonderful. Pascal, do you have any burning questions sent to you?
Yeah,
otherwise absolutely.
I will go. I got actually two questions on the positive, on the negative side. So the first thing which I find is very convincing to everybody using contrast-enhanced mammography, and you made that point absolutely clear, is that the ease of access, contrast-enhanced mammography is simple. You mentioned, however, one thing that could well make this more difficult, and another thing you didn't mention. So two questions. First, if you're an iodine deficiency area, do we really need blood tests? Because that would annoy me a lot. Second, do we really need contrast-enhanced stereotactic biopsy, or how often have you wished for that?
The first question, could you repeat it a little bit? Because
yes. Sorry. Do you need blood tests? So we are talking about screening or problem solving or staging. We want to do contrast-enhanced mammography now. In which case would you need any blood tests, like for the thyroid function?
Okay, so I think in general, when you look at, for example, the biggest thing is, of course, the renal impairment. We struggled with that in the beginning because, of course, we applied the same conditions as CT. And again, especially if you start doing these kinds of things, to make your life easy, follow the same protocol, because then you're already covered with that. Do not change too much in your department at one go. But we wanted to offer contrast-enhanced mammography immediately. And the whole idea behind that is that we did a study by Ivo Huben, one of my former PhDs, with stat sensor, which is a finger stick analysis, to see whether it was sufficient to use that as a sort of point of care method. So we took that measurement, but we also took whole blood samples. So we had for 400 cases also whole blood samples of people just walking into mammography room without any complaints, and we took a sample and we took a finger stick analysis. Now, in the end, that analysis was not accurate enough, so we could not use that. But in the meantime, in our department as well, there was the amazing trial by Joachim Wilberger as one of the primary authors, which showed that prehydration is not always beneficial for patients when you use it. And based on that paper, the eGFR level was lower to 30 in our country to think about prehydration. We already knew the data of that study, so we published it, but we kept our raw data of the whole blood samples, and we already looked at in how many cases did we drop in that population below 30? None of the cases. So that sort of convinced us to say, well, we use a questionnaire, and if everything is no, we made it the questions like, if you always answer no, you don't have an eGFR below 30. And we tested that again, that protocol within the RACER trial, and you need to keep up with adverse events, serious adverse events. The only adverse events that happened in the RACER trial are extravasations or hypersensitivity reaction, but nothing related to kidney impairment. And same goes for thyroid function, and the same goes for metformin. We just did it and prospectively look what happened, and the effects of an outpatient population, which is just walking into your mammography room and says, I don't have anything with my thyroid, I don't have anything with my kidneys, and I don't have any diabetes, they do not get into trouble.
That's a very, very good and very pragmatic point, Mark, because in our country, it's a bit difficult because, you know, we are in the mountains. They say we are an iodine deficiency area. There could be a problem with the thyroid function. I did really a literature review, and actually there's no, that is such a low level of evidence, and it's such low level of events. So I also think that's absolutely ridiculous to think about it.
It's the same, like we had the discussions with the COVID vaccination. There was some discussion about thromboembolisms and everything, which were very rare. And then we should always say, how often is this occurring, and how much benefit are we doing with contrast enhancement? That's the whole balance. Of course, I always say you never want to be the one who has an allergic reaction. Actually, I had a CT scan once in my life, and I thought, well, you will see. In my own department, I'm the one with the hypersensitivity and anaphylactic shock, of course. But it turned out fine. And then once you did it, you know, I'm not allergic to iodinated contrast.
Second question, Mark. The second thing was with, do you ever need stereotactic biopsy like contrast enhanced mammography? So how often have you really wished for it? Because I think if you really need a specific device to biopsy specific findings, then we are back at the MRI thing where you say, oh, you can only do MRI if you have the opportunity to do an MR guided biopsy. So is it really needed? So hand on your heart, do we really need a contrast enhanced mammography biopsy unit in order to do contrast enhanced mammography?
The honest answer is no. The reason why you're asking it, and I'm sure but it makes your life easier. The honest answer is no, because when you have an enhancing only lesion, we always had a workaround with breast MRI. In almost all the cases, you see a lesion on the diagnostic MRI, and then you can target it with breast MRI. Actually, we're in several years, we were so convinced that we left out the diagnostic MRI, and we immediately send them to the targeting MRI, so to say. So it's your workaround. If you have it in-house, it's no problem. You can organize it very quickly. But in Zuiderland, in our region, we tend to centralize the MR-guided biopsy to have sufficient experience within the Maastricht University Medical Center. So we refer them, but then you already have maybe a 2 weeks delay. Patients has to go there, do the biopsy, get the results back, and then it's easily 2 weeks before they get back with the MRI guided results. So again, if you already buy a system and you buy an upright or anything for stereotactic biopsy, it's actually just an extra software license that you buy with the current systems, and then you're able to do it. And then actually, if you don't have to recall them for that, you can do it in your own house within 2 or 3 days to leave some room between contrast. So the honest answer is no. But as I learned from a very good colleague of mine from Tromp Medical, he tends to say it's a nice to have, but not a must have.
Great.
And I fully agree with that. It's nice to have, but it's not a must have.
Great. And Matthias, sorry, I know you have lots of more questions collected, but I have one question because I realized that many people, actually I had the same experience. When I started contrast-enhanced mammography, it's exactly what other people think. Everyone expects that the contrast is as high as an MRI. They actually look for the showcases. The cancer should be bam in their eyes, and then they say, well, the contrast is so low, it's very difficult to spot the findings. What would you suggest then people to do in order not to be disappointed of the contrast?
My recommendation there was if it's difficult on contrast-enhanced mammography, it's difficult on MRI and vice versa. If it's not much enhancement on contrast-enhanced mammography and you hope to delineate it a little bit better with MRI, you're going to be in trouble because it's going to be difficult with MRI as well. Sometimes with dense breast and you have a lot of background enhancement and it's very difficult to delineate the mass on contrast-enhanced mammography, we sometimes do a breast MRI as addition because you have a little bit of extra tools with DWI and the curves to see whether there are any other spots in the glandular tissue that attract your attention. But this is very tailored then that you use the MRI. Again, it's not that we never do an MRI, but we do it very tailored to an individual case. But
yeah, I absolutely agree. You have really to look yourself into it. I mean, you have to familiarize yourself with the technique, and then actually, in the end, it's not the same technique. It's the same underlying principle, right? Yeah. But it's
and if something is not very well vascularized, like mucinous carcinomas, they tend to show moderate or poor enhancement, but it's the same on MRI. You can easily overlook them as well there.
Matthias, I guess you got a question because otherwise I could discuss with Mark all day long.
Pascal, it's not only you; it's the whole audience. So thank you very much. I haven't witnessed this kind of engagement in a symposium during the last months, at least. And our symposium are usually very, very engaging. So thanks for everybody of you who ask questions. I try to sort out the general sort of roadmap of the question because it's impossible. I feel like 30 questions here, but some of the questions are circling around the narrative of background enhancement. Of these difficult breasts. I mean, we are all here experts looking at the first. So what about BPE, strong BPE cases, MR versus CEM? Yeah, and the tiny lesions, the tiny little, you know.
Yeah, I know that from a publication by the group of Maxine Jockelson. As you know, is a very good friend of mine, and you already heard in the last symposium that we share the same birth date. So that's why we had an immediate connection, not only on a basis, but also on a birthday basis. It's very easy to remember her birthday, I can tell you. But the thing with background enhancement, you can have it on MRI, you can have it on contrast-enhanced mammography. And in that study, they looked at what rate is it interfering my diagnostics? And how did it look on MRI? And sometimes you see that it interferes your diagnostics, but on the same level, it interferes with your diagnostics on MRI as well. So again, if it's difficult in terms of BPE on contrast-enhanced mammography, it will be difficult on MRI, but sometimes you have these small things that you can sort of abuse, like the signal intensity time curves or DWI, or you can get a little bit of extra information to what we usually do is actually confirm that what we saw on contrast mammography is actually the only thing and that we're not overlooking anything.
Right.
So it's roughly similar. In terms of planning it with the menstrual cycle, that's also a very common question. In fact, we tend to not do that for breast MRI also anymore. We had experience, we learned to deal with it, and it's almost it's unplannable anymore. There are patients who are just continuing their strip of oral anticonceptives. you have implants or anything, a large number of the population is 50 plus, so they are perimenopausal or postmenopausal, so either they don't have a cycle or they have a very irregular cycle. And the very small amount of women that we can plan it, which is roughly the screening population of BRCA gene mutation carriers and anything, they have such busy lives that they usually say, well, I cannot make it today, can I come next week? So in the end, we had a lot of no-shows, we had a lot of wrong appointments that in the end, we just said, we're going to stop it. And it doesn't really lead you to very big problems.
Beautiful. And there was another question regarding location of the tumors. So is there any location where we would say, okay, this is not really good because there would go for MR, and if yes, which one?
Close to the chest wall. So we can assess chest wall invasion. Very close to the nipple if the surgeon wants to know whether there is involvement in the nipple because of nipple sparing mastectomy or anything like that. In the medial part of the breast and high in the axillary tail. These are just places that are, from a mammographic point of view, are very difficult to get in the field of view. And if you assume that there's a tumor there or you see it on ultrasound, then go for MRI because you have the overview much better. And again, if you, for example, have a tumor behind the nipple and she's going to have a full mastectomy, well, then there's no need for an MRI anymore. So again, very tailored to when are we going to use the MRI? If the surgeon says, I want to do a nipple sparing mastectomy, then we need the information from the MRI. You see it much better there.
Matthias, I got another question. I read it in the list actually, but I think it's also interesting asking someone who is doing it for so many years. What is your take on post-biopsy contrast enhanced mammography? Is it an issue? Do you try to do it before biopsy, or what's your opinion? Because one of our audience asked and said he or she has had some issues with that.
You can have some issues with that. Similar to MRI, I also have cases in which you see some non-mass enhancement right after biopsy, but we do not plan the biopsy. We want to immediately have an efficient workflow, and the chances that it interferes with your diagnostics is very low. Sometimes you can have an hematoma, which with contrast enhanced mammography can be difficult, but we do the biopsy after we do the contrast enhanced mammography. And there's a little bit of a strength if you have, for example, a biopsy done before and it's a cancer and you want to then do something with perfusion and you have an hematoma, then I would prefer MRI, because with the non-contrast T1, you usually see high signal intensity of the blood, and you can distinguish which is blood and which is enhancing mass. So again, that's really tailoring to what do you need, what do you want to know. But yeah, you can have a little bit of non-mass enhancement, but usually it's not in line with your ductal pattern. You need to know how the breast anatomy works and how a breast cancer grows. It's always in ductal patterns. So if you have one line which is directly across it and you say, did you biopsy from the medial side or the lateral side? And that if that coincides with the one who did the biopsy, then you already have the problem solved. So I think you can figure it out quite rapidly.
Great. And once again, I really like the narrative of you demystifying the virtual battle A versus B. I mean, this doesn't make sense. You have to find a personalized solution, because there's no one size fits it all tool, which is beautiful. Which brings me to probably one of the final questions, but well, maybe we can start a second round. This is more of a global thing. It's not just a classical diagnostic thing. What's the roadmap of you being one of the leaders here to get this done? I mean, on your level, very pragmatic, you just get it on the road, you do it, and that's it, and convince the people. But we are all well aware, if you do it like on a public health level, maybe in the UK, whatever, what would be the major steps? And we learned, for instance, from the DANCE trial that just creating evidence is not enough to change something. So what's the roadmap, or what would be the major steps?
I think for us as sort of pioneers, and I have several very good international colleagues, which we're trying to have our voice heard across the world with all these dilemmas that for example, management or government can throw up at you like the radiation dose, then we need to have evidence that radiation dose is not the discussion that we need to have. The next thing that you always hear is, well, we don't have any reimbursement. So we're not getting paid for the examination. That's a very well-known dilemma. I said, that's not true. You don't get reimbursed for the contrast. You get reimbursed for the mammography, which is 3/4 of the examination. For me, as a chairman of the whole department, I rather invest in perhaps 30 euros of contrast, which I need to pay for myself, and do an extra MRI for neuro, which is much higher price. So you get your workflow much more efficient. And sometimes you need to, well, pay a little bit yourself to free up space somewhere else. And these are all communicating vessels. So it's very, and this is also very difficult to capture in one simple study design, that when you tweak something on your department at one side, it has an effect on a different specialty and a different modality on the other side of your department. So you really need to be very smart in your discussions with these people at management level, because they don't have the medical insights. They only think about how much does it cost, how much are we going to spend, do we really need to spend it? And so sometimes you get lucky, sometimes it's a very difficult discussion. And again, right now for having additional funding for the DANCE2 trial, it took us 4 years, just to give you an impression how long it sometimes can take when you're talking with government and everything. And if you talk about a lot of money, this is a project which is sponsored with millions of euros on the long trajectory. So it's just being an expert panels, being in consensus panels, having your voice heard, and just keep pushing without being a very bad person, of course, because otherwise you do not get it. But be smart. And sometimes it's very easy to, actually, to be honest, when I first did it, I had a discussion with our IRB committee, and they said, well, is this research or clinics? And I said, well, what's the difference if I have a chest x-ray and I see a nodule? What do? Contrast, CT. Contrast, more radiation. So what's the difference now? I see a small nodule on the breast and I do contrast with a little bit of more radiation. And they said, well, actually, that's a very good statement. So they agreed that we could use it in clinical practice. I have it in writing. That was all agreed upon. Now, 2 years later, the new chairman of the IRB committee said, well, I was of the opinion that it was research. And if I was the person in charge back then, I would have not allowed it. But I said, well, you weren't the person in charge right then. So sometimes you're a little bit lucky. Sometimes you really need to push and keep on it. And I cannot give you one miracle solution to do it. If you start using contrast-enhanced mammography, I always say start small. 1 patient a day, review the images together as a radiologist, perhaps do an extra MRI because you're familiar with MRI and see how it looks on contrast-enhanced mammography. So allow your time. Do not try to do it as us with immediately 5 cases a day. That will come. We are not super scientists or super doctors. We just took it step one day at a time, 1 case, then a rest period, see what we did, can we learn anything from it, and then the next day another one. Small baby steps, and then increase your volume.
That's super pragmatic and really impressive and much appreciated. The only difference which we have compared to you is that we can learn from people like you. You have the experience. So once again, we are super grateful. I think I'm speaking here on behalf of the whole audience, including Pascal and myself, that you share your time. And there are 2 questions maybe we can still discuss. We already like 10 minutes over time. Maybe we have a second take of this eventually, because it's overwhelming how many questions I've been asked. Like there's still 20, 30 on our list. I'm convinced, and most of our audience is convinced as well, that this really makes sense. I mean, this is not the discussion. The question is, where do you use this tool, right? Because as you said, you're a mechanic and you work a lot with your hands. Not every tool is perfect for everything, but if you go to screening, I still have little problems, but probably because I'm not as knowledgeable as you are. I'm not a radiation physicist. I never got this really well in medical school, but what I understood is the target group, and you made it perfectly clear of patients. Well, it's actually not patients, participants who will benefit likely most are the younger ones, right? It's not the 80, 75-year-old ACAA breast. And here you really have a difference in the risk. Yes, you're right, of radiation or mortality, whatever, induced kind of stuff. You're right, obviously, in a low scale setting, like assessment, problem solving, staging, no discussion, you got me. But if you have a examination which you do on a scale of millions, then even a low risk, which may be super low, I got that point, is scaled up. And then you will have a difference compared to a different setting. Yeah. For instance, screening dense person. This is just something I would just discuss.
Absolutely. I fully agree. And perhaps we're not talking about doing everybody doing screening with contrast-enhanced mammography with everybody, but just figuring out. Right now in the Netherlands, we have a one-size-fits-all screening strategy. Everybody gets a normal full-field digital mammography. But there's maybe a subpopulation which could benefit from tomo. Maybe there's a subpopulation who could benefit from contrast-enhanced mammography. So we're going from a one-size-fits-all to an individualized screening. And if you ask me, sometimes people ask you, how would your ideal screening look like? If you have unlimited money and limited resources, and you think plainly from your experience, what would be the ideal? Now, for me, the first round would be contrast-enhanced mammography for everybody. Why? You have a very high sensitivity and a very good specificity. So you virtually capture all the cancers. You don't have these underlying occult cancers. You have the power of an MRI, so to say. So you keep your baseline a lot. Then you have density measurement, because that's always the problem. You always need one mammogram to measure density. And then you can sort of perhaps say, well, AB is sufficient to do every 2 years or maybe every 3 years, a normal mammogram. C is tomosynthesis, and D is contrast-enhanced mammography, maybe even in patients more rural or mobile units, because you already had the first uncomplicated contrast-enhanced mammography in the hospital. The chances that you then get a hypersensitivity reaction in the following up is becoming even more or less. But that's an ethical discussion, whether you want to keep it in the hospital or are you feeling safe enough to do that outside the hospital as well. But that's really future talk. But start with contrast-enhanced mammography and then make a triage in what kind of individualized screening protocols that we should follow.
But you're not only clinically and scientifically, but also from the management aspect, you're really, you can feel that you know what you're talking about, which is really a pleasure, because, you know, in these times we have often people speaking about things because they have some conflict of interest in it, because they're not really doing it because for some pure political reasons, and you have it all in one hand, which is really quite impressive.
Thank you for your compliments. I fully agree. I feel the same way about you. So I'm very much looking forward to our small battle in Tromsø and the end of the year. And maybe for the next contrast-enhanced mammography, we will do the same battle, but then you will give a talk about contrast-enhanced mammography, and I will take the side of MRI. Just for fun.
That's fair.
So that's my challenge. I hope you will accept that at one time.
Lovely. This has to be witnessed. It's gonna be a great session. Thanks. So then I only have like 2 minutes left to do a quick wrap up, because you will be interested in what's gonna be next, because this obviously won't be the end of SAM at the School of Radiology, and obviously beyond. So just thanks for all of you who already gave us the feedback poll. This is not about fishing for compliments, but this really takes a lot of effort, but most of all by Mark. So thank you once again for being here with us, sharing your time. You're running a department, you're a world-renowned scientist. You just took 1.5 hours, which are the most precious of the day, because this is between 8 and 9. This is lovely. So thank you very much, Mark. This was outstanding. And we also have to thank every one of the audience and all the 63 countries following the session, because you also shared the passion and the enthusiasm of Pascal and myself for this topic. So thanks very much for being here with us. And thanks also to the team behind who is running this, because this is not a small project. It's getting bigger and bigger. And this is why we really would like to read your feedback, your evaluation, You just reach to us anytime on whichever channel you prefer. And obviously you would like to see each other again. We're doing contrast enhanced mammo sessions regularly on case reading, because we agree with Mark, we have to do hands-on training. It's not only about reading papers, publishing the latest, hottest stuff. No, we have to do really hands-on training, discuss. And this is why we are so passionate also about teaching. There's a full day workshop coming on November 11th. So only a few days left. Make sure not to miss the early bird or us on whichever channel you want. This is not about promoting us, it's about promoting your mission and your knowledge. I think this is so important, but because people are really, eager to do that. And talk about sharing your knowledge, there are cutting edge articles published by Mark. There are so many, we just selected 2, and they are all accessible at our homepage or on Google, wheresoever. These are just landmark papers which may serve like as a small script. There were also screenshots during the talk of Mark who can be found here on our webpage or in the internet, wherever you want. So that's for me, that's for now. It's been a pleasure. Stay tuned with us at the School of Radiology. We will post all stuff related to this outstanding symposium. And once again, thanks, dear Mike, for being here with us, sharing your knowledge and your vision, and most of all, your passion and drive, because the drive is really impeccable of you. And in that, this is really amazing. Yeah, that's from our side. Unless, Pascal, you want to add something more?
No, just again, I think I said everything I need to say. Great for everyone who stayed so long with us. I mean, I'm not astonished. I enjoyed it a lot. Mark, it was a pleasure having you here. Absolutely so.
Likewise.
Yes, a standing ovation. There's a huge wave of standing ovation here in the studio. And you guys at home, thank you very much, and stay tuned with us. There's gonna be a lot of stuff coming out, and maybe there will be a farewell. Goodbye.